weekly. Sama niya ako schedule. Hello? Oo, tama. So anyway, so the lecture to release this afternoon will be on parasitic infections among immunocompromised hosts. Uh, so in behalf of Dr. Psycho, I will be the one to present to you the parasitic infections among immunocompromised hosts. So remember, everything you've learned about um, infectious disease. Uh, it's just simple. Everything is different when you're dealing with immunocompromising conditions. Okay? Um, when you're actually kung ano yung magpiling na immunocompromising conditions, actually, it depends. But strictly speaking, when you're talking about immunocompromising conditions, um, for most part, we're talking about patients with hematologic malignancy, like myelinogenous leukemia, patient on active treatment for malignancies. Pero this one, more or less, temporary siya. So, for example, patient underwent uh, chemotherapy for solid tumors. Whereas, in a sense, during the active treatment, you may consider this patient as immunocompromised. Um, what else? Patients on chronic steroids, but yeah. Number three, in some immunomodulator drugs. So, immunomodulator rituximab. But for this specific drug, we're talking mostly on patients. Ang effect of this immunomodulator drug, its effects are mostly on a specific arm of the immune system. So for example, with rituximab, you're talking about its effect on cell-mediated immunity. So this is in contrast to yung mga induction chemo, for example, anthracycline, wherein its effects are more wide or a more broad coverage or a more broader depression of the immune system. So include your innate and your cell-mediated response. Okay. And lastly, we forgot to mention among patients who have HIV or AIDS. So throw everything out of the window, your understanding of immune response. Immune response in regards to infection when you're dealing with immunocompromised. They may present differently. So your typical response to ongoing infections like your fever may not be seemingly benign or opportunistic infections may present as something that is severe. Unusual pathogens or infections that could be considered benign among patients who are immunocompromised. So, host defense is the first and foremost feature of the immune response. So this actually forms the barrier between, for example, the spirit area, like your brain, like your vascular system, or your peritoneum. It will form a barrier of sorts. Okay, then follow the inflammatory response. So these are negated by your circulating phagocytes. These are all non-specific. In response to your what? Pathogen-associated molecular patterns or in response to damage or not damage associated with the cellular protein. Then what follows are more delayed but more specific for the adaptive immune system. Include cell-mediated and humoral response. Okay. So generally, for the protozoans, these are not affected by inflammatory response. Resistance to infection is determined by the reticuloendothelial system. Remember, the bigger they are, the more susceptible they are to the reticuloendothelial system. And the effectivity of the tissue phagocytes depends on the ability of the organism to resist necessary steps of antimicrobial activity. Actually, this part, the last statement, we're talking about depends on the ability of the organism to resist necessary steps of antimicrobial activity. Is what we call, in short, the virulence. Okay? Uh, in response, will it be evasion or will it be destruction, enzymatic destruction of your immunoglobulin? Um, Facilitation of attachment are some examples that facilitate uh, the virulence of the pathogen or its ability to cause. So, T lymphocytes and B lymphocytes are the major component of the cellular immunity. And depending on the disease, or depending on the pathogen, both the T lymphocyte and the B lymphocyte, or the cell-mediated arm and the humoral arm, depending on the pathogen, each of these arms of the immune system will actually cause or will actually prevent or pose a danger to this pathogen. So it depends also on the type of lymphocyte. You have your CD4, the CD4, your CD8, or cytotoxic. Then your CD4 cells actually divided into T helper cells, TH1 and the TH2. B cells, on the other hand, in response to your activation of your memory cells, will differentiate into plasma cells and will activate the specific immunoglobulin in response to ongoing infection with a specific pathogen. So, HIV-related opportunistic infections, bacteria, fungi, and protozoan. And of course, the diminished CD4 cells are actually one of the predictors of how severe the infection or how susceptible the host is. So the lower it is, the more susceptible your patients to a variety of opportunistic infection. And also, the lower your CD4 count actually affects the prognosis of the patient in response to the disease. So this includes markedly reduced positivity, activity, and of course, chronic uh, chronic wasting or malnutrition um, will also depress the immune response. When you're talking about staging of the flu, always remember that this staging are not used in terms of in the clinic. These are actually for epidemiology purposes. At most, this staging does not, in most studies, does not show any significance or clinical significance. So we do not usually use this staging in terms of when a patient comes in. Okay? But on the other hand, the T lymphocyte count, so the CD4 count, actually has its clinical significance. The lower they are, the more susceptible to infection, and the lower they are, the more worse the prognosis, especially if these patients have not been initiated with the. So number one, for the more parasites, we have the Strongyloides pecoralis, Strongyloides. So the Strongyloides infection is predominantly TH2, or with high levels of interleukin 4, 5, 10, and 0 IgE. Remember, the parasitic infections, 0 IgE, and the eosinophils are one of the first and foremost defense against this infection. So, in immunocompromised, this strongyloides infection may present as severe and complicated and will disseminate all over. So it results from increased generation of filariform membrane or accelerated infection, typically when host immunity is impaired. Um, there are only two parasitic infections that could cause autoinfection. One is strongyloides, and the other is what do you think? Aside from the strongyloides, or what are other parasitic infections that could cause auto-infection? Wala ko na nababasa ng po. I'll just take Arias Bianca.
Hello, Doc. Good afternoon. Si Susama, Doc.
Yes?
Hello, Doc. Good afternoon.
Oo.
Susama,
Yes,
Doc. Si Susama, Doc. Si Susama. Can I be heard, Doc?
Louder, please.
Si Susama, speech. Si Susama, Doc. Doc, bation ka, Doc.
Susoma. Schistosoma cause auto-infection. Sige, isa pa. One more.
Pneumocystis jirovecii.
Wala ko. Remember, yung cystis is everywhere. So, tama siya tawag nila ng opportunistic.
Mga ivermicularis, Doc.
Sige. Okay. Makuha naman ko isa pa. Si Irish. Irish. What are other pathogens that could cause auto-infection?
Sorry, Doc. Topic, what other factors? What was your question, Doc? Cause hindi masyado bation.
Hindi ko masyado batian, Irish. Hello?
Hello, Doc.
Oo, hindi ko masyado batian.
What was, Doc? What was other factors?
Teka, before I ask the question, batian niyo po hindi.
Ara, Doc, pero hindi masyado Doc clear kay may noises, bala, Doc.
So, meaning from the start, hindi ko batian? Tama? Am I right?
Oo, Doc. Mabatian ka, Doc, pero hindi masyado, klaro.
Siko? Okay, okay. I'll ask
Ang
again.
background, Doc.
I'll make some adjustments. Kung hindi nyo ko mabatian, kayo kanina, kung hindi nyo ko mabatian, so, ikanubol. So, mabatian nyo ko hindi. I can make some adjustments.
Mabatian ka lang, Doc, pero may ang background sa likod, Doc, mas gagaw, Doc.
Ginahod niya po lang sa background.
Yes, Doc. Pero mas
So,
batian.
hindi ko klaro eh. Hindi
Doc,
ako klaro.
klaruan lang,
Klaro
Doc.
ako hindi.
Aara na,
Mas
Doc.
klaro sumo.
Oo.
Okay. Sige. Okay. Klaro ha? I can make some adjustments. Tama?
Yes, Doc.
Okay.
Mas better na, Doc, compare earlier.
Okay. So, Irish. Question ko, what are other pathogens or parasites that could cause auto-infection?
Vermicularis, Doc.
Anong first name yun? Ano yung first name?
Enterobius, Doc.
Okay. Duha lang na sila actually. Pero most one of the two things you get to ask sa med school or exam that could cause auto-infection. Okay? So to proceed, sino ba na itong president? Sino ba na itong president? Or, not president, mayor? President ba yan? Oo, Carmine. Oo. So, Carmine, namalungo ko kung hindi na ko mabatian, ha? So, the common use, actually this one, important is use of corticosteroids, the risk factor for disseminated strongyloides infection. Okay. and it's a chronic steroid use. So a mean daily dose would be equivalent to 52 milligrams of prednisone. Okay, listen to this. When you define chronic steroid use, that's almost 4 weeks or 1 month, and at least at a minimum of 12 milligrams per day. The mean is 52, so meaning it's higher than that. But the definition actually medyo valid for most studies I've seen is that it's 20 milligrams per day for the last 4 weeks, okay, or 1 month. Okay. Other risk factors include TNF alpha inhibitors or other immunosuppressive drugs. Yung TNF alpha is mostly sa rheumatologic disease. Some hematologic malignancy. Okay, hypochlorhydria. There's some case reports wherein disseminated spondyloides infection in terms of diabetes. HTLV, although I haven't seen this one. HTLV or human T-cell lymphocytic virus 1, almost similar to your HIV. Okay, and it has been associated by promotion of HTLV to T-cell leukemia or lymphoma. I think HTLV, you get to see HTLV mostly in Japan. Double check. So, strongylitis in HIV worldwide, the malnutrition and use of steroids. The lack of association of HIV with severe strongyloiditis may reflect a decrease in production of TH1 cytokine, increase in TH2 cytokine. So, there are two types, diba? TH1 and TH2. So, your TH1 is actually more associated with HIV. So, there's a more or less a compensatory response into a decrease in CD4 counts, or in terms of proportions. So, complicated, severe strongyloitis, and an immune reconstitution inflammatory syndrome with abdominal pain, vomiting, and anorexia being reported after institution of antiretroviral therapy. So, next, we have the schistosoma disease. So, HIV co-infection treated with the cystic egg extrusions, patients with ethnophobia and hematobium, hematuria. So, in a sense, there's a decrease in recognition of the infection. So, this decreased recognition, decrease in inflammatory. So, however, because schistosomiasis appears to increase susceptibility to HIV infection, especially when there is a presence of genital lesions. So, this may increase the viral load, progression of HIV disease, and increase in HIV transmission. So, treatment of schistosomiasis in persons with HIV infection has led to a decrease in HIV viral load, increase in CD4, and decrease in schistosoma fecundity and egg excretion, not full killing. And remember, the immune reconstitution phenomenon, or what we call IRE, manifested the eosinophilic colitis with granulomas around dead and dying schistosome. This is fascinating, actually. When you think about some diseases wherein there's may walling of the formation of granuloma, like your TB, in severe HIV or with association of low CD4 counts, the presence of immune reconstitution, so the patient has already started ART, antiretroviral therapy. There is, in a sense, a decrease in the destruction of your CD4 T cells. And what follows suit is that this destruction of your CD4 T cells, there is, in a sense, inflammatory response or an immune response. So medyo naging florid na ang response mo, rather than a more depressed immune response prior to the initiation of your ART. So next will be your arthropods or the sort of KB or KB. Okay. So uh, close contact is really important. I report in remember this institutionalized and immunocompromised patients with HIV. A typical form of KB, basta, when you think about KB, think about institutionalized patients. Yeah. So double whammy, institutionalized ka na, immunocompromised ka pa. Okay? Okay, so this one medyo mas obvious, but sometimes you have to look more closely, and correlate it with the history in terms of diagnosis of your TB. So sometimes the presence of secondary infections. So we have here on the left figure, there is impetigo. So co-infection with Staph aureus. Okay. Medyo obvious na po. For this one, okay, for any insult, secondary impetigo or secondary impetiginization. Okay, next and most important, pneumocystis jirovecii or PCP. So diffuse ground glass or bilateral reticulonodular pattern. Sometimes it could present as bilateral or diffuse ground glass. Sometimes you're going to be presented with a patient with a normal effect. The diffuse ground glass will be sometimes so fine that it takes a more experienced eye, especially among physicians who are well versed in the management of patients having PCP or physicians who have high index of suspicion that this patient has PCP. Okay? Frequent cause of pulmonary infections in 85% of cases. Pre-H, hindi talagang tawag sa mong heart, ARTs na lang, period, antiretroviral therapy. Okay, and sometimes this is the initial presenting symptoms of patients who are not diagnosed with HIV. Initial presenting patients who are admitted at the hospital. Okay, CD4 cells are actually less than 200 most of the time in the viral load, with a heavy burden in terms of viral load. Most of the time, clinical acute course is subacute. Okay. This patient may present may not present with fever, the subtle complaints of exertional dyspnea, and with or without stomach. Some do not. So most of the time, one of the most specific symptoms for me, especially when you're suspecting in a patient, when a patient has HIV, is the exertional dyspnea that has been going on for the last 1 to 2 weeks, or a subacute course of exertional dyspnea. So in this one, in terms of diagnosis, you had to have a high index of suspicion. Okay, so it occurs in patients who are neither receiving ART or not on PCP prophylaxis. Most common CD4 count is 20. Pero usually, or most of the time, it's less than 200. Okay? Fever, non-productive cough, and dyspnea. Be mindful of the dyspnea part. Okay? The dyspnea part sometimes is really, really common. Patients will just complain of exertional dyspnea or of dyspnea in terms of effort. So you have to ask them for in terms of comparison. How were the patients before and during this time in terms of activity? So for example, before he could walk at least 5 kilometers. Now at 100 meters, the patient is already dyspnea. Okay? Normal PE is more of a rule, and abnormal chest PE is more of a rule. Most of the time, these patients will present with a clear breath patch. Bilateral fine reticular ground glass capacity of 80% in some studies with very higher interest rate. Okay, ito medyo obvious ito. And when we get to see this one in cases, most of the time in in correlation with the patient's clinical status, you will already take the diagnosis of a PCP. Okay, some abnormal findings include pneumothorax, lobar pneumonia, cavities, lymphadenopathy, and diffusion. Diffusion is rather uncommon. And a normal chest X-ray register at 10 to 15%. So, yung costically proven unicystic cervixi, bilateral is the most common. Bilateral, multilobar, and diffuse. Pero when you look at it, on the horizontal part, almost all are findings suggestive of PCP. So there's rather no specific, or almost everything could be representative of PCP. But if you get a bilateral, multilobar, and diffuse, and reticular pattern in correlation with your clinical presentation, you can almost have a high degree or high degree of suspicion that this patient has PCP. PCP or Immunocystic Cervixia. I think the new name is Immunocystic Cervixia. The old one is the PCP and Immunocystic Cervixia. Okay, so high mortality rate between 30 to 60% in patients having low partial pressure of oxygen. These patients may be likely able to walk but with low oxygen saturations, anemia, recurrent PCP, and those patients severe enough that they need ICU admission. What remains the drug of choice? 15 milligrams, 20 milligrams per kilogram based on the trimethoprim component. Okay? Most of the time, wala ka di IV. When you get, we do have IV trimethoprim in Manila, but most of the time we give oral trimethoprim or trimethoprim, and the dosing is 800 milligrams over 160. So the 160 is the trimethoprim part, and the 800 is the sulfonamide part. Hello? Pati on ako. Klaro ka? Or do I have to change the location? Klaro hindi. Hello?
Medyo
Para,
loud
Doc.
background noise. So,
Klaro hindi. Or do I have to change location?
medyo
Sige.
loud ang background noise, Doc.
Okay. Malag up pa lang ha. Okay. Nang malag up pa lang ha. Kaya ma-change na lang ko location. Okay?
Persistent and asymptomatic presentations are common. Okay? In the late stage of, however, of HIV infection, this may present as an opportunistic infection and may present with typical combinations of fever, hepatomegaly, splenomegaly, weight loss, and pancytopenia. So again, this correlates to the levels of your CD4. So AIDS patients have extensive GI tract involvement, and that includes oral mucosa, esophagus, stomach, and the small intestines, and may present with chronic diarrhea. Lung and pleural involvement presenting as effusions, and bone marrow presenting as aplastic anemia also have been described. So the incidence of leishmanial OIs have decreased with the introduction of modern antiretroviral drug regimens, but the number of cases with visceral leishmaniasis HIV co-infection may increase as it continues to spread among leishmania in the endemic regions. So problem post-treatment relapse of visceral leishmaniasis and predictors of relapse again, CD4 counts greater than 100. So akin to more or like an iris. Okay, an increase in CD4 T cell count on follow-up, use of secondary prophylaxis, and prior relapse. Okay. Okay. Another protozoan that could cause bacterial vaginosis. So HIV-associated trichomoniasis in several African studies. So local inflammation often caused by the parasites. So a lot higher among patients with HIV co-infections. So an increased number of cases among patients with HIV co-infection. Okay. So the associations between HIV and trichomoniasis as well as other STDs may relate to the following. So increased shedding of HIV as a result of local inflammation produced by the STD. Okay. Increased susceptibility to HIV as a result of injury, cellular injury, and most of the time is either macroscopic or microscopic breaks. And higher prevalence of HTDs among HIV-infected individuals as a result of common risk factors for both infections, and increased susceptibility to STD associated with immunosuppression. So we have injury, either microscopic or macroscopic, prevalence of STDs among this subset of populations. Number 3, the immunosuppression itself causes increased susceptibility to the disease. Sorry, ano gali ha? I stand corrected. Hindi gali vaginosis. So sala, it's trichomoniasis gali per se. Okay, trichomoniasis as STD per se. Next, the RNA concentration of HIV in the seminal fluid of men with urethritis was significantly higher in men with trichomoniasis than in those with symptomatic urethritis with an identified cause. So successful treatment of trichomonal urethritis reduced the level of HIV RNA so that they were similar to those seen in infected control subjects. Okay, another parasites. So cryptosporidiosis, so diarrhea. Okay, this is an opportunistic infection that would cause diarrhea. One of those parasites. So CD4 counts plays a role in the susceptibility of the infection, and the lower the CD4 counts correlates to a more disease or to a severe disease. So this one fulminant in those counts with less than 50. So no actually treatment restitution of your immune response. So this time effective antiretroviral therapy, and what follows is the influx of CD4 counts into the STDs. So clinical manifestations are variable, and among patients with CD4 counts greater than 150, most cases of cryptosporidiosis are self-limited, similar to those in normal hosts. And chronic diarrhea is associated with frequent foul-smelling bulky stools. So, I need this one a lot less common. So involvement of the biliary in the respiratory tract most of the time is asymptomatic. So, but may present with bilateral pulmonary infiltrates with dyspnea. Okay, pero this one haven't seen one yet. And I think the problem with this is actually the diagnosis per se. But biliary tract involvement or respiratory tract involvement for those patients having profound immunosuppressions. So may present with calculus cholecystitis, sclerosing cholangitis, or pancreatitis. So metabolic studies of AIDS patients with chronic cryptosporidiosis demonstrate fat wasting. So again, like for any chronic diarrhea, so you have fat wasting, decreased absorption. Again, the chronic part, actually, there's a malabsorption na component in regards to the chronic diarrhea caused by the cryptosporidiosis. Okay, so again, this chronic this malabsorption syndrome, this could be a combination of malabsorption of bile acids, vitamin B12, and the fatty acids. Okay, next, ito ha, for almost all those things, since you're still in med school, one of the dapat hindi nyo ginmalipatan, pneumocystis jirovecii or pneumocystis, some physicians call it pneumocystis carinii. Then this one, the toxoplasma gondii or the toxoplasmosis. Okay, infections with human immunity deficiency virus. Okay, almost all of us are infected. Okay, but it's rather asymptomatic. The problem is, in terms of profound or immunosuppression, they may cause a reactivation of the latent infection. Okay, and especially not just HIV, but it could also occur among organ transplant patients, and or it's either new or reactivation of a latent infection. So HIV infected patients usually present with focal neurologic symptoms, and most of the time these patients are IgG positive and IgM negative. So in a sense, you may encounter this in the clinics, that patients with suspicion for toxoplasmosis, most of the time these patients are IgG positive. IgG positive, meaning they're already been infected with toxo, but this may present as a latent reactivation of infection. Okay, it cannot establish the disease, the diagnosis of the disease. However, in some cases, wherein, well, you may get lucky. You may get an IgM positive patient. So medyo it may help you in the diagnosis of the toxoplasmosis. Okay? But we do clinical diagnosis, medyo mabudlay siya i-diagnose. So what we do is clinical correlation, high index of suspicion, especially immunocompromised, and those patients presenting with CT findings of contrast-enhancing lesions. Okay. You may get lucky if you can do biopsy, so improved by immunoperoxidase staining, but most of the time it's a clinical diagnosis. Okay. And one of the things that is important in managing patients with toxoplasmosis is the response to treatment. So, ang usual na clinical scenario with that among us ID physicians was that in a patient with HIV, presenting with multiple contrast-enhancing lesions on CT, we treat them with, well, the treatment for toxo is forthright. And we are expecting response in a matter of days or matter of 1 to 2 weeks. So, we do repeat CT, and if there's a resolution or a decrease in the abscess or the enhancing lesion, then by itself, this is a diagnosis for toxo. Okay? This is one of those cases where you do not wait for a definitive diagnosis. So for immunocompromised, pyrimethamine plus sulfadiazine, but not available in the Philippines, plus glucoverine. Alternatives, we have atovaquone, but in here in the Philippines, we give trimethoprim sulfamethoxazole. Okay. Actually, in some studies, almost equal for the pyrimethamine plus sulfadiazine versus cotrimoxazole. But given that we have limited choices, so actually medyo nami na ang response for the cotri versus the for patients having toxoplasmosis. Okay, in this one, be mindful of your iris. So ARTs are started after 2 to 3 weeks of treatment. And toxoplasma medications if CD4 count is greater than 200 for more than 6 months. So be mindful of the relapse rate without ART and maintenance therapy. So these are all your combinations. Medyo tanan nga bulong di actually hindi available except for the cotri. We don't have pyrimethamine. We do not have sulfadiazine. We also do not have atovaquone. So that will be the end of my lecture. Any questions? Sorry, gid sa background noise kagina.